I will be discussing the issues with the management of post-operative nausea and vomiting, also known as PONV. Major problems related to PONV that I believe need to be addressed include the issues and complications PONV leads to, challenges with the preventative strategy, and lack of gold standard with the management of PONV. During the first 24 hours after surgery, post-operative nausea and vomiting is a common side effect that occurs to patients who are administered anesthesia. It is usually the reason why patients illustrate a sense of dissatisfaction during the post-operative period. Pre-operative surveys reported by Peer and Whelan have shown there is a high interest from patients to avoid PONV. Issues that arise when patients suffer from PONV can include an increase in patient discomfort, delayed discharge, and also delays in mobilization. PONV can also result in complications such as fluid and electrolyte imbalances, suture tension, esophageal tear, abdominal wound dehiscence, and increased intracranial pressure. Approximately 30% of the population experience PONV. Due to a vast amount of the population being affected, there is need to address PONV due to the negative impact it has on the patient's quality of life. This is reinforced as patients around the world are willing to pay money to prevent them from suffering from PONV. Additionally, PONV contributes to the increase of medical costs due to delayed discharges and unplanned admissions. The current management of PONV include the use of pharmacological interventions as well as implementing preventative strategies. Pharmacological treatment includes the use of antiemetics. A combination of antiemetics, for example using ondansetron, dexamethasone, and droperidol together, improve results which effectively clear the encounters of nausea and vomiting. If the patient has not previously received preventative treatment, a 5-HT3 receptor agonist such as ondansetron should be the first treatment of choice. It is recommended that an antiemetic from a different class should be administered if prophylaxis has already been given. Pharmacological treatment will not help all patients experiencing PONV, so it is crucial to be aware of the possible adverse effects that may occur. Preventative strategies have also been invented so patients do not experience events of nausea and vomiting post-surgery. A common strategy that is implemented to prevent PONV is decreasing the related risk factors. This approach integrates strategies to eliminate and decrease the baseline risks of PONV, which effectively reduces patient discomfort. There have been well-established risk factors that have been identified for patients who are affected by PONV. Studies from Habib and Gan show that patient-related, anesthesia-related, and surgery-related risk factors existed among patients, which contributed to PONV. Some of the risk factors involved are female gender, history of motion sickness and PONV, general anesthesia, and insertion of a nasogastric tube. Challenges arise when risk assessing to attempt to decrease the baseline risks in patients. When assessing the occurrence of risks of PONV, Blackburn and Spencer illustrates that this strategy only predicts the chances of PONV in a population, not the individual. Therefore, it is imperative to cater for the individual and appropriate treatment is implemented. It is also clear that PONV may occur even when no risk assessing is applied. This reinforces the challenges that are faced when undertaking a risk assessment. Another issue that has been developed is there has been several recent risk factors that have been disproved. There have been numerous potential risk factors that were considered to contribute to PONV, but a few of these were found to be invalid, such as obesity and the menstrual cycle. With the continuousness uncertainty present, this imposes the difficulties related to risk factors due to its multifactorial etiology. There is a gap in knowledge about the prophylaxis and treatment of PONV as it is explained by Eberhardt and Crank. It has been more than 12 years since the first international recommendations for the prophylaxis and treatment of PONV were published. These recommendations were brought up to date only twice within the last decade. This illustrates there is no gold standard for the management of PONV. This is supported by Obrink, Gildenstall, Odby, and Jacobson, as they comment that there is only a general recommendation for the prevention and prophylaxis of PONV. This justifies the gap in knowledge as it reiterates the inability to solve the problem of PONV, highlighted by the limited incorporation of up-to-date information about PONV. Eberhard and Crank expresses their desire for continuous improvement to be enforced with the unsolved issues of PONV to improve patient outcomes. The lack of determination to improve is apparent as Crank stated that Anesthesiologists presented a poor attitude towards solving PONV by voicing they were tired of waiting. This emphasizes the lack of intent to progress and attempt to solve the problem of PONV. It is important to close this gap in the near future to decrease the unwanted consequences of PONV, resulting in an improvement in the patient's recovery. In order to expand the knowledge of PONV, there needs to be a willingness to conduct further research and not accept that no more can be done. As mentioned before, antiemetic treatment can be used for the prophylaxis of PONV. Even though there is no gold standard for the management of PONV, the current guidelines need to be adhered to and followed in a proactive fashion. Compliance with antiemetics was significantly low with patients who were considered to have a reasonable amount of risk factors. In another study mentioned by Crank, only 2 out of every 3 patients were treated with the current guidelines. This puts a strong emphasis on the poor application of PONV management in the clinical environment. It was stated by Conway, during surgery, patients who were looked after by a certified RN anaesthetist received prophylactic antiemetic treatment majority of the time, but those who were attended by an anesthesiologist did not. A way to minimize PONV can be having a certified RN anaesthetist on site, which may increase the compliance rates of antiemetic treatment. A potential way to minimize the PONV issue is by furthering the education of nurses involved with the recovery of post-operative patients. Studies performed by Youthwaite determined nurses lacked adequate understanding to provide evidence-based interventions to patients suffering from PONV. Improving their education in areas such as the cause, complications, treatment and prevention of PONV can be beneficial for post-operative patients. The lack of education is evident as the nurses only knew 60% of the necessary knowledge to effectively manage PONV. With the lack of a gold standard, this could contribute to the continuing of PONV incidences. Further research needs to be undertaken to create this gold standard that clinicians are yearning for, as there is no guarantee patients will be free of PONV during recovery, and there is still no drug available that reduces risks of PONV.